I'm going to start the recording and let James and Catherine unmute themselves. There we go. All right, Annika, start whenever you'd like.
Alrighty, sorry for the slight delay there. Of course, technology never works when you want it to. Hello and welcome to all of you who have joined us for this online media briefing. I'm Annika Dean from the Australian Science Media Centre. Today's briefing is a little different to our usual ones in that there won't be any presentations like we normally have. We're just going to jump straight into our expert Q&A around the potential lifting of Australia's COVID-19 restrictions and other related topics. Today we're joined by Dr. Catherine Snow and Professor James McCaw, both infectious diseases epidemiologists from the University of Melbourne. Thanks for joining us online today, Catherine and James.
Thank you.
To ask questions during today's event, you just need to type them into the Q&A box, which you'll see on the right-hand side of your screen at any time, and just to make sure to include your media outlet as well. Please make sure that you're using the Q&A box and not the chat box, which are both there. I will then read out each question. For those of you who have joined us over the phone, I will give you the opportunity to ask questions when we unmute you at some point during the event. So I'll kick things off with a fairly obvious one. This can be for James or Catherine, or you can both jump in. We've seen positive signs that Australia is getting control of COVID-19. When are we likely to see restrictions end?
Who wants to go first, Catherine?
That one, you can have that one.
Sure. So I actually think it's not quite the right question, to be honest. We need to work through what restrictions we may or may not be able to restrict before we start talking about when. That's the short answer. I think it's worth unpacking that with some follow-up questions, either from you or from others.
I guess an obvious question would be, what do you think is the first thing that we could start to open up? We've already seen things like elective surgery be brought back in. What do you think is the next thing that they will likely broaden out?
Right, so I'll answer, and then I'm sure Catherine will have some other things. So there's two sorts of things that we need to be thinking about in terms of reopening, and for different reasons. So the elective surgery, the reason we're thinking, or the government is thinking about reopening or looking to reopening that, is because due to the control measures, we don't have an overwhelmed hospital system, and so there are things that we can reopen to allow those other aspects of society to function and to keep people healthy for other reasons, and hip replacements and whatnot. So elective surgery was suspended because we were trying to ensure that we had a hospital system that was going to be able to cope with a surge in cases due to coronavirus. The other sorts of questions we have to face are, can we lift or modify restrictions around epidemic transmission and control of the virus itself? So they're two different things. I just saw that slide pop up. I think it's actually really helpful. Where did it go? If we look at the epidemic curve in Australia at the moment, its peak was a few weeks ago and it's coming down. An incredibly important thing to keep in mind whenever we're looking at those epidemic curves, and we see them in online and in the media and on the government website, is the reason the case numbers are now low, the new case numbers are low, is because of the control measures. It's not because the virus has run its course. The vast majority of Australians, absolute vast majority, I suspect it's more than 99% of us, are still susceptible to this infection. And so if we relaxed our restrictions, we would see a surge in cases in exactly the same way, if not worse, than as we saw in late February and early March. So any idea about lifting restrictions needs to be in the context of maintaining epidemic control, because the virus is still there, the virus will come back. And this gets to the elimination and exit strategy discussion, which I'm sure we'll get to later. So the first things you would be thinking of are things that allow us to relax, are things that will allow us to manage the spread, the inevitable continued transmission of the virus, while enabling us to, have more activity in some sense, either economic or social or well-being. And I'll finish there.
Did you have anything to add, Catherine?
Yeah, look, I mean, a couple of things. I think James is exactly right. There's sort of multiple different dimensions to each type of social distancing or control measure. So as James says, one of the reasons that you can go back to elective surgeries is that our ICUs are not as busy as we expected that they might be at this time, although they could get busy again in future. The other sort of flip side of that, of course, is that some of the things that are quote-unquote elective surgeries are still quite urgent. They have quite significant quality of life implications for people. They have quite significant medical implications for people. A lot of Category 2 and Category 3 surgeries are not the kinds of things that you can safely put off for 6 months or 12 months. So that's the reason I would imagine that that particular restriction has been relaxed, because although you can put those things off for a little while, you can't put them off for a year. And so, and obviously that's quite particular to elective surgery, but there is this, sort of balancing act between, okay, well, what are the risks for transmission if a particular restriction is relaxed? And also, what are the consequences of not relaxing it? And the consequences of continuing to very strongly restrict elective surgeries are quite severe for the people who are impacted on by that. So that's sort of the framework that you think about in terms of which restrictions could we relax. There are transmission risks, but there are also, other harms. There are equity considerations in terms of who does it impact and how badly does it impact them, and is it impacting some people very severely and other people not at all. And so that comes into play in terms of, other restrictions that we're talking about. When you see people talking about schools or who could go back to work, there are those factors at play as well. What's the risk to transmission, but also what are the harms or benefits of restricting or not restricting that particular activity? But it's not the case that all of the restrictions that we have currently are going to be gradually relaxed over the next month. That's not what's going to happen.
Because otherwise the virus would spread and we'd look like Italy.
Absolutely, and that could happen extremely quickly.
Yeah, thank you.
We have a question here from Heather Saxner from Australian Doctor. Heather asks, how do you weigh up the economic consequences of COVID-19 restrictions versus the health consequences? And she says, by health consequences, I mean both the risk of outbreaks if the restrictions are lifted and the risk of chronic disease during restrictions.
Right, so again, I think we'll both have something to say here. So the first thing is I really think it's incredibly important to not frame it as weighing up one versus the other, and indeed the second part of the question acknowledges that. The cost to the economy, and I'm not an economist, right, nor is Catherine, so it's important for that work where we have collaborations with them, and we've worked as a whole, as a broader group of people who are involved in working through these whole of society. So, but just like Catherine said before, action or inaction both have economic consequences. I think it's, and this is beautifully put by the open letter by many economists that was signed and I think republished in the conversation in the last few days. So one thing I would also do is refer you to that letter, which very eloquently describes how it's a health and economy response and broader ethics and all sorts of issues. And yes, within there are trade-offs. Clearly, the social distancing measures in place at the moment have negative economic consequences. But the flip side is true. Letting this virus sort of, as some people have bluntly said, letting this virus rip through society would have even greater economic consequences. We would have, they're fanciful numbers, they're terrifying, but 300,000 Australian deaths in a few months and a health system that no longer existed, so that to be a little bit dramatic, but it's sort of true. Someone in a car accident may die where they would have been saved because the health system's not there to help. So how we do those calculations is ultimately a question for the health economists and the economists, and there are some excellent people with those skills in Australia, but they can take a utilitarian approach or other sorts of approaches where they try and put a value on everything, so through dailies or qualies, and then they try and figure out that balancing act. There's a lot of uncertainty in the virus's behaviour. There's a lot of uncertainty in what the economic consequences of what's going on now are, because society's somewhere that it never anticipated it would be. So those calculations are very difficult, but some people are attempting to do. I'll finish there.
Yeah, so I think I completely agree with James that framing it as sort of public health versus the economy, I think, is really not accurate at all. As James says, having an unmitigated epidemic would be absolutely catastrophic, both in health and in economic terms. I think another thing to have in mind, obviously, these restrictions are having huge economic consequences, including for individuals. Many individual people have lost their jobs. But some of those consequences can be mitigated, and we've seen that. We've seen huge mitigation activities from, state and territory and federal governments against some of those economic impacts. We've seen, payment rates for the dole doubled basically overnight to help protect individuals against the economic consequences of losing their jobs, and lots of other measures from government as well to mitigate some of those economic harms. Those measures are incredibly, incredibly costly. But so is an overrun ICU. Intensive care and, an emergency care is very, very expensive to governments. So allowing our ICUs to be overwhelmed or even just to fill up would also have tremendous, tremendous financial costs for governments. So it's a very complex question about how do you weigh each of these individual things. How do you weigh job losses versus the stock market versus health costs? They're very complex questions, but there's no easy way out of this in economic terms. There's no choice in front of us that has a good economic outcome where our economy bounces back tomorrow, unfortunately. This virus is going to have huge impacts on our economy no matter what we do in the next few months. And clearly a lot of people are putting a lot of work into figuring out how to mitigate that, both for individuals and for businesses and sort of for the economy at large.
And we'll stay on you, Catherine, as we have a follow-up for you. You mentioned previously, this question's from Ahmed Youssef at SBS. You mentioned previously that not all restrictions will be lifted. Could you give some examples of things that you think won't be lifted?
Yeah, so again, this comes back to sort of complexity. I know what I, as an infectious disease epidemiologist, consider very high risk, but some of those things might have economic or other benefits that I'm not thinking about or that I'm not aware of. But from a transmission perspective, things that I would see as highest risk and therefore hopefully least likely to be relaxed would be international travel, because that would create an ongoing risk of significant numbers of people bringing the virus back into Australia. And each of those could potentially start new outbreaks. And then the other sort of category of things would be mass gatherings. So things like conferences, large sporting events, large weddings, things where a lot of people are in an indoor space for a prolonged period of time. Because what we've seen overseas is that there have been very large outbreaks, and in Australia actually, associated with conferences and weddings and events like that, where you have a lot of people, shaking hands, kissing hello, sitting next to each other in a room for hours and hours, sharing food, all those sorts of things. So I would not expect those types of measures to be relaxed anytime soon. I imagine James would have some things to say about this as well, because I think this is occupying a lot of his time at the moment.
It certainly is. So I'm happy to follow up. And could you just put up my slide? And I know some people can't see it, but I'll refer to it. publicly available. Host, can you,
I think he's just grabbing it now. Oh, he's giving you control.
Okay, and then I can do forwards. Okay, so what I've put up on the screen is our most recent plots of the effective reproduction number, and for those who can't see it, we've been updating these about once a week for a while, and we've been presenting to the government for longer. So these are estimates of the effective reproduction number, which is how many people how many new cases arise from current case in Australia. And that number is currently under 1, which is why the epidemic is in decline. The question about what restrictions we can lift and relax comes down to a measurement problem as well. So any increased mixing within the population will result in increased transmission if the virus is present. The question is, how much will it? And the answer is that at a detailed level about schools or mass gatherings or public transport, we don't know. We don't know how important each individual mixing opportunity is to the overall transmission dynamics of the virus. We don't know for influenza, which we've been studying for 30 or 40 years. So it's very simply a hard scientific problem to figure out. The other thing that makes it challenging right now is that we put in Australia and all around the world lots of interventions all at the same time. We had to. It was a very good thing to do because it's what averted disaster in Australia for now, and it's what's helped get control of out-of-control situations overseas. So then the challenge is, what do we do now? So if we, and the strategy that I believe the government's taking from public announcements and from the conversations that I've had, are that we have to take this is a science conference, a media science sort of media event, so we take an experimental approach. There are some things we can't model and can't predict, so we're going to take an experimental approach. So if we relax, let's say we let public, or we encourage people to use public transport more, or we allow the football to run, we will monitor very carefully, and one of the monitoring systems is measuring this effective reproduction number. And that effective reproduction number will increase as we relax an intervention. If the effective reproduction number gets above 1, then we know that we're going to have growing epidemic again. And depending upon the long-term strategy, we might tolerate a small, very slow-growing epidemic, or we probably wouldn't, and so we would then have to restrict it. And so the rational and logical policy approach here is to try one thing, monitor it very carefully, and see if we could tolerate it in an epidemic transmission sense, and also measure the, estimate the benefit in a, say, social and economic sense. And so there are some things that we'll have to, we'll release, we'll allow to occur, and we'll have to decide, no, actually, they were too risky because they increase transmission too much. And that's not a mistake, that's simply the reality of how you learn about what's going on. So the effective reproduction number is one way. I'll finish there.
While you have those slides up, James, it does raise an interesting point about the difference between the transmission in the states. We've seen some states, such as Western Australia and South Australia, record days with 0 new cases. Is it likely we'll be able to lift restrictions differently across states? Sort of the more western states will be able to lift restrictions a lot faster than the eastern states?
I think ultimately, yes, this is a possibility. We need to be very cautious at the moment because we don't yet know if there's anywhere else in the world, so this is certainly not a criticism. We don't yet have the enhanced surveillance system in place that we will need to be absolutely confident that we do pick up any residual infections or new importations that might be surprising, but I'm sure will be possible. So until that surveillance system is up and running, it needs a dramatic expansion and investment in people, logistics, reagents, everything. We need more time to have that system there up and running. It's a very, very difficult task to get going. Once it's in place, yes, it would make a lot of sense, and we hope would be achievable to have subtly different responses and operations in place across different states and territories which reflect their local epidemic activity. Again, this will need to be done in an incredibly cautious way.
I think I would just add to that as well that a state is also quite a large unit.
Yes.
So you can have really significant diversity within states in terms of what's going on. And we're seeing that at the moment. New South Wales has a much bigger problem in Sydney than it has elsewhere in the state at the moment. And obviously in Tassie in the northwest, they're having sort of a focal particular problem. And so obviously you need stronger measures in places that are having, more significant transmission or more significant challenges. I think the other difficult issue in Australia is that some states, although they have relatively small numbers of cases at the moment, also have areas that are particularly vulnerable. So WA and the Northern Territory and Queensland, to an extent, don't just need to think about what's happening at the whole of state level. They have a lot of regional and remote communities that are very, very vulnerable, where even 20 cases could be a complete disaster. And there's something like that happening in Cairns at the moment where, Cairns is a small place, its health system is quite small, and, having 6 health workers knocked out of circulation because of one case has a really significant impact on their ability to manage their outbreak. So I think we also need to be a bit careful when people in some states are thinking, we're doing pretty well, maybe we'll be able to relax things. Everything is very fragile. Everyone is still very vulnerable, and especially regional and remote centres are very, very vulnerable, and their situation could still change very, very quickly. So as James says, that relaxation has to be very careful, and there has to be a really good system in place for detecting problems, including in regional and remote areas.
We've got a question here from Grant MacArthur at the Herald Sun. Grant asks, to what extent is suicide being monitored and or modelled in terms of balancing social distancing versus the risk of virus death? And a follow-up is, how is this impact weighed and weighted in terms of lifting restrictions?
It's an excellent question, and it gets to the heart of some of the incredible challenges that society is faced with. And I think that's, in a sense, that's the starting point, is we need to be thinking as a society about all of these issues, because there are so many health issues related that are non-COVID directly. There have been discussions in the school, Melbourne School of Population and Global Health that I'm part of, about these issues. So the academics who specialise in mental health and suicide prevention are engaged with the infectious disease epidemiologists like Catherine and me broadly. There's a huge amount of activity going on around other issues related to the line of questioning here around domestic violence, safety of children, all sorts of. Modelling these things is very difficult because what models do is build from some elements that we know to extrapolate in as clear and clean a way as possible to what we might anticipate. And at the moment, particularly when we get to the questions like what you've asked, is we don't know enough. Society has never been, well, it's not quite true, but society hasn't for a very long time been pushed into the structure that it's in now. And so anticipating how humans respond under these situations is something that's just very, very difficult. And so I think rather than modelling, the key thing here is to be aware of it and society is aware of it, you as a journalist are aware of it, and the academics who specialise in this area are aware of it. And then you have to measure. And so I know there are surveys being done and conducted to try and understand how people are responding, how they're feeling around things, these very sensitive issues, whether or not there have been increased reports to, and we know there have actually been increased phone calls to places like Lifeline and other things beyond Blue. So at the moment, it's not really a modelling question, it's a measurement question. And the only reassuring thing I can say is that the people who focus on this, they are paying attention, they're very aware, they're talking to the infectious disease people. Ultimately, how we trade, it's such a hard, I don't like saying it, but I will, but trade these things off and try and balance these things is a matter of equity, ethics, perhaps economics, but I think we've got to be, these things are difficult to work through. So yeah, the people are talking about this and thinking about this and doing what they can to understand what the consequences are. And ultimately, the peak decision-making bodies, recommendation bodies, and then the government who make decisions on these things have essentially impossible choices to make. I'll leave it there. But thank you for the question. I think we need to talk more about these issues.
Catherine, anything to add?
Look, I completely agree with James that it is a very, firstly, it's a difficult thing to measure and a very, very difficult thing to model, but obviously, as James says, efforts are ongoing. And I think that's true of a lot of things. Something that I've been concerned with and that I'm happy to see more discussion of is the impact of all of this on people with disabilities, for instance, who need care. They need, or many of them need care, and, they need people from outside coming into their house on a daily basis to assist them with activities. Many of them need support from younger family and friends that will have been impacted in various ways. So there are a huge amount of issues like that are tied up in this, and it's nowhere near as simple as, infection control or transmission reduction on one hand and other impacts on the other hand. They all interact with each other. Mental health.
Oh, keep going.
And that is something that everyone's thinking about, and I hope that we'll see more discussion about those those issues and the interactions between those issues in the coming weeks. Something that I've been a bit concerned to see in some of the discussion is, some people are asking, well, is it fair to ask young people to give up so much and sacrifice their jobs and give up many of the things that they value in life just to protect the health of older people? And I think that's actually a bit of a false dichotomy as well, because we know that an out-of-control epidemic would also have terrible health consequences for young people. So all of these things interact, and a lot of people now are trying to start getting their heads around what the interactions are and all of these different health consequences. And I hope we will see a lot more discussion about that in the next couple of weeks and couple of months.
Yeah, I've got two things to add then, and these are just following up with Kevin. So on the latter point about younger people, if you look at the statistics of the ICU occupation in Italy, it's 30 to 50-year-olds, not the elderly. They never got even an opportunity to get there. So an out-of-control epidemic, back to the first question 20 minutes ago, an out-of-control epidemic affects everyone. And then the other thing, back to the original question around mental health, domestic violence, and how we help different people in society, I was incredibly reassured to see reports out of the United Kingdom about a week ago, and so the details I'll refer anyone who wants to report on this to the source, just relaying it, that people who are on the spectrum in some sense, who really, really need contact with more people for their mental well-being, have been given an exemption, my understanding, from some of the social distancing and travel rules within the United Kingdom, or not travel, but use of social spaces and parks and whatnot. They've been given an exemption because the risk-benefit trade-off purely from a health perspective was reevaluated to say these people, yes, by mixing more, there's a risk of transmission, but the social isolation would be so damaging to their health more broadly that there have been exemptions given. So I think some subtlety around how this all works is something that needs further exploration and consideration, especially as these interventions go for longer. But I would refer people to the actual, I only know that through monitoring the media myself, so it's not, but please follow it up if you're interested.
We've got a question here from Penny at the Medical Republic. Do you think the government's 3 goals of increased testing, tracing and capacity to respond to local outbreaks, if they are achievable, will allow some return to normality without the virus getting out of control?
Yes. There's a shortest answer of every given. How much return is the question, and that comes back to what we were talking about before. But the cornerstone of a effective public health response to this infectious disease is the ability to detect where it is quickly and respond effectively and rapidly. And that comes down to increased testing capacity and well-targeted testing, plus an ability to do something when you find a case very quickly, which is isolation of the case and effective quarantining of their contact. So yes, how much that enhanced ability to slow the transmission allows us to free up more general social distancing measures so that we can just mix more in general is a question that we can't answer yet, but it will definitely, the idea is it should help, or it will help, it's just we don't know how much.
I think just one thing that I would add to that, though, is that it is still a complex scenario. And I think, we're seeing some people in some places talk about, well, if you could test enough people, then we could completely lift all of the restrictions and we could completely go back to normal. That, unfortunately, is in no way realistic. So
Absolutely.
even though we need... Yeah, so we definitely need to improve testing capacity so that anybody who needs a test can get one. But at the same time, there will still be people who just feel that they have a little bit of a cough and that they don't need a test and who won't get a test. And so we still need enough social distancing and other restrictions in place so that when that type of event happens, someone who has the virus and isn't aware that they have it isn't going to a conference with 3,000 people. They're not going to a wedding of 400 people and kissing 20 relatives hello, or they're not going into a crowded workplace, with an open plan office. There will always be some people who are not picked up by a surveillance system. There's almost no surveillance system for any disease anywhere in the world that picks up every single case. So we still need enough measures in place that when cases do slip through in Australia because people aren't that well or that unwell, or they don't have good access to healthcare for whatever reason, that the consequences of that are not out of control transmission. So we do need to improve testing and we do need to improve surveillance, but no matter how good it gets, we will still need other risk mitigation efforts in place. And for this virus, that means social distancing until we have a vaccine.
I agree.
Sort of jumping around the questions, but this one sort of leads into what you were discussing. Can you, are both of you able to tell us more about the surveillance system? What are the elements and when do you expect it to be functional? This question's from Jill Margot at the Financial Review. She missed some of your section, James, and wasn't sure if you said it would be used to measure the rest. Right,
so we measure the effective reproduction number. I love that it's now called the ref. It's like the referee making decisions. It's just one part of it. It relies on a stable and efficient or good detection and reporting of symptomatic cases. And so that system is largely already in place and excellent in Australia. But it's only, our effective is only one way of looking at the epidemic, and we need to look at the epidemic in many, many different ways to be confident that we understand it well enough so that we can then manage it most effectively, balancing off health and economics, which is the recurring theme of this discussion. So an enhanced surveillance system needs to look at the epidemic in many different ways so that we understand it as well as we possibly can. So there are many elements to the system. It is still in development because there's lots of different data streams. We have a distributed health system across 8 jurisdictions with different laws. But it's also just a difficult scientific problem to work through, which is how do you design a health system or a surveillance system, that is able to detect this virus. No one really has ever tried to develop a surveillance system with those properties for humans. And so it's a new thing to do. It's going to have lots of elements. It's going to have virus testing. It's going to have studies designed to monitor, say, households to try and pick up hidden transmission. So where you swab people who don't show any signs of infection, so these are like sentinel systems as well. It may have, we've seen reports of it in the media, it may have systems in place to detect the virus in sewage, because we know humans excrete the virus. It's probably not infectious, but we know that monitoring of the sewage system, so it's like an environmental monitoring system, and we know we use that for many other things in society, environmental compliance and whatnot. So that might be part of the system. We don't know how useful or important it will be yet. Clearly worth considering. We need blood sampling to detect antibodies, so immunological responses to the virus. That tells us more about the epidemic. We probably need to, a surveillance system will extend to monitoring people's movements. We've seen Google's mobility index published that shows that we're spending more time at home and less time traveling and things like that. So there are all sorts of aspects to a surveillance system that will come together to help us understand what we are doing as people in society and what the virus is doing. That's all. We need more time to pull that together. It's both a scientific thing and an operational thing. But it's well underway, and when it's ready and implemented, it will be communicated presumably by the government.
I've got a question for you, Catherine. I think it's a follow-up to when we were discussing the difference between the restrictions in the states. Do you think, would things like campsites, provide the risks you were mentioning?
The risks that I was talking about with things like conferences and weddings are about when you have, a large number of people who are all indoors, all together interacting, for many, many hours. So, a campsite doesn't make it into that category because people are usually staying in their own tents and they might be using a common kitchen or a common bathroom. So there is a risk there, certainly, but I wouldn't put that in the same category as things like conferences and weddings, no.
Can I just add to that? Right now, we've shut down everything because during March, because we had to take a cautionary approach to avert disaster, and we have. That doesn't mean that long-term everything like that has to be. The other part of that question, though, around camping, and I'm a camper, and a biker and a bushwalker, is even if those activities were shown to have minimal risk, we do need to think carefully about the fact that as part of them is that people travel longer distances. And so the camping might be fine, but filling your car up with petrol at a country town which had not yet exposed the virus, that might be the event that sees the virus and spreads it. So I'm not saying it is. I'm not actually making a comment about whether or not the policy, we should or shouldn't allow camping. I'm just trying to explain, it's a really complicated question.
It's complicated.
The camping is fine, but maybe there are other things. And so we need to think about spatial patterns as well. So I really like the question because it reinforces that where it sounds like a simple thing, there are often other important things. And so nothing here is simple.
And I think the other thing to add to that with camping in particular is that it often involves travelling to remote areas where the nearest hospital is far away and small. And something that will be really, really important for all of us this year is to not do anything that could put undue pressure on small regional hospitals. And that's whether you go camping and then you wind up with the virus and you end up having to go to the local hospital, or whether you fall hiking and break your leg and have to go to the local ED. Our regional hospitals this year really need as much pressure taken off them as we can possibly achieve. And so anything that involves travelling to a small town or a regional or a remote area creates a risk to the health services in that area that they really can't afford.
And that campsite question was from Ahmed Yusuf from SBS, who has another question too. What do the panellists think of the reopening of beaches in Sydney?
Look, if people in society adhere to the recommendations around social distancing, I don't have any in principle issue with it at all. I think it's one of these things where we humans are a social being, and it's a challenging. We benefit. Our mental health is improved by spending time outdoors in the environment, particularly at times of stress. So, but ultimately, it's going to come down to people's behaviour. So when those beaches reopen, we see a huge wave of people returning, and those beaches are packed. They'll be closed again. It's as simple as that. How that issue is managed is not something that I can comment on, because as an infectious disease modeler, I can understand the consequences of these things. But I'm not in a position to predict how humans will behave. Maybe no one is, but certainly not me.
Yeah, I agree with that. I think, and I think it's also about making sure that people sort of have the foundational knowledge they need to make reasonable risk assessments, and to understand that going to the beach by yourself and going for a swim or going for a surf is very different to meeting 10 friends at the beach for a barbecue. Right, those two things have a completely different risk profile. So, or going to the beach with a group of mates and all sitting next to each other on the beach, sunbaking for 4 hours, has a different risk profile to going for a swim by yourself. So, I hope that as people get a better sense of what types of activities create a risk of transmission or don't, that people will start to make good decisions about, okay, well, the beach is open. Okay, I'll go for a swim, but I'm not going to sit there with 6 mates for 3 hours, because those two activities are not equivalent in risk, even though they both occur at a beach.
We have a question from Natasha Robinson at The Australian. Natasha asks, does Australia have a chance of eradicating the virus, and is this a worthwhile goal to have?
An excellent question, and I'm glad it has the two parts. So, from a purely technical and scientific point of view, yes, we do have a chance, by no means guarantee, of eradicating the virus. Depending upon how much asymptomatic transmission there is, that is transmission from people who do not know that they are ill, if there's more of that, it makes it harder to eradicate. But the effective reproduction number is currently under 1 on average across the state. And if we held that for long enough, we have our borders closed, like we do, then yes, there is chance that we eradicate the virus. We might have to wait a very long time. There are good mathematical models that describe that path to zero, from near zero to zero, and there's a lot of variability in it. It might take a few weeks or it might take many months. So that brings us very naturally to the second question, is should we? That's a much harder question to answer. And there's two reasons. The first part is what I just referred to, which is that it might take an incredibly long time, and that actually could be quite costly, because to eradicate it, you definitely need to stay locked down for, if we start talking about opening up aspects of the economy or society, we will, the virus will spread just a little bit more, so we would definitely reduce the chance of eradication. But to me, that's also the minor issue. The real issue around the so-called elimination strategies and the eradication strategies is, where does it leave you? And we have to work on the assumption, and the people who have thought about elimination definitely understand this, is that the virus will be re-imported. No border is, Australia has a border. We have an advantage in that we're an island, but we don't have a perfectly controlled border. Of course, we don't. Things happen, either mistakes or malicious activity would be guaranteed. And so the virus would be re-imported. And then it comes back to this question of the surveillance system is, can you have a surveillance system that picks up those inevitable re-importations quickly enough such that you don't have to go back to a full lockdown or whatever it happens to be. So I think the more you look into the elimination and eradication strategies, the more they actually in practice look similar to a strong viral suppression strategy, because the surveillance systems that you need for both of them are very similar, and the sort of expected, the need to probably modulate your activity and respond again is probably quite high for both of them. So it's not a magic solution as well.
Yeah, and I think the other thing to say is that I'm getting a sense that some people are seeing that, the R effective has come down a lot and that our numbers of new cases have come down a lot. And they're seeing that as sort of guaranteeing that, well, now we have it under control, and so they're going to keep going down and we're pretty much out of the woods, or that we could eradicate it. And James is right that there's a chance, but there is a huge element of luck in this. There is a significant random element, because like any epidemic is a random, unpredictable process. It's a bit like a bushfire. They can change direction, they can get bigger and smaller very quickly. And so when you're talking about eradication, or even when you're talking about control, even with the restrictions we have right now, we could see a large outbreak. We're seeing a large outbreak right now in Tasmania. And there are a lot of risks and sort of networks of people that we can't completely break up and we can't completely mitigate. So right now we're seeing very low numbers of new cases. If COVID gets into a prison in Australia, that will change very rapidly. We've been very fortunate so far in Australia that it hasn't gotten into very many nursing homes, but it could, because people have to go in and out of the nursing homes because they have to go to work and they have to provide care to people. Exactly the same in a prison. There are many, many people who have to go in and out of a prison every day because that's where they work. And any one of those people could take the virus in. And it's luck so far that means that they haven't. So that could still change. So, this R effective is a reflection of what is happening, but it's not a guarantee. The fact that it's low right now is fantastic and is a really positive reflection of everything that we've done, and that so many people have pulled together and done the right thing to drive that number down in Australia. But it could still go up even if we didn't ease restrictions. The virus could get into a high-risk setting like a crowded essential workplace, a prison, a large nursing home, and set off a large outbreak. That could still happen. So we're not guaranteed any particular outcome with any particular set of restrictions. They help and they're very effective, but there is still a really significant random element. We could get lucky and eradicate the virus, but we could also get unlucky and see more large outbreaks. That is a possibility still, even with the restrictions that we have right now.
The bushfire analogy is a very good one. It's been used quite a lot. And at the moment we have spot fires, but spot fires can have a habit of surprising you and forming a big fire front, and then you'll have to deal with that in a different way.
Yeah, and you would never say, oh, don't worry about that fire, it's not that big.
It's a very good analogy.
Not how we approach that. That's not how we approach that problem.
Heather Saxner at the Australian Doctor asks, are further measures needed to reduce the impact of worsening health as patients put off face-to-face consults with GPs? Anecdotally, she says, restrictions are scaring patients away from seeking healthcare outside of telehealth.
So I would start by saying it's clear from public statements from the Chief Medical Officer of Australia that this concern is held at the highest levels of government. We can see the anecdotes are concerning, and in fact, my understanding is that we can see some of those issues in some of the systems as well. So how to mitigate those adverse health effects of the coronavirus response is a key consideration for the Communicable Disease Network of Australia and the Australian Health Principal Protection Committee, and then ultimately the government. And I can't say, well, it's not that I can't say, if there's nothing else that I can add from my professional point of view.
These questions can somewhat be combined. Ahmed from SBS asks, if there is an outbreak at a prison, what would you recommend should happen? And Jill Margot also asks, are immigration detention centres at risk too?
Yes, they're both high-risk environments, and they're both very, very challenging environments for infection control. So I'm sure there is a lot of thinking and planning going on in that regard in terms of mitigating those risks, but those risks are very, very significant. There are things that you can do to mitigate them, but the physical structure of prisons and immigration detention centres and the way that they operate makes infection control in those centres very, very difficult. In the same way that it does in a nursing home, there are just structural factors in terms of the way that they operate that means that completely separating people is difficult. So yeah, they are very high risk settings, and it is difficult to completely control an outbreak in one of them. So prevention is very, very, very important.
Yeah,
prevention is much easier than control.
Yeah, and I would just add that these are also questions of justice, ethics, equity. We're talking here about disenfranchised members of our population for different reasons, but those two different examples perhaps, or perhaps for different reasons, but nonetheless, I think a principle of public health is that we should be focusing across the entire society and looking in particular through that global view, also looking to support in particular those who are most disenfranchised or most vulnerable, and asylum seekers and those in detention and in prisons are particularly vulnerable and deserve attention as a very important aspect of how we respond. I think how society chooses to respond to the management of risk for those populations says a lot about the society and the values it holds.
Yeah, and I think it's also very important to recognise that those are not separate settings that are completely quarantined from the rest of society. People envisage them that way. People imagine that a prison is a completely self-contained environment and it's over there, and what happens in a prison doesn't affect the rest of us, but it absolutely does. Staff go in and out of prisons every day and they go home to their families, and people in prison move in and out. The average amount of time that people spend in prison in Australia is only in the order of weeks. So there are many, many, many people who move in and out of prisons every day. they're not a contained environment that the rest of us don't have to worry about. They are part of our society. And as James says, they contain many of the most vulnerable people in our society who, when you meet them on the street, you recognise as intensely vulnerable and in need of help. But then somehow they go into prison and we all kid ourselves that they're people who are over there who have nothing to do with us. That's absolutely not the case.
How can data from overseas guide what happens in Australia? Is there specific countries' data that we should be looking to use?
I'm happy to start the answer, but I'm sure we'll both have some things to say here. So at different phases of the response, it's very different. So in late January, when I started working on coronavirus and helping support the government, or mid-January almost, provide advice to the Australian Commonwealth, there was one or two infections, or I can't remember the numbers, a handful of recorded cases in Australia. And so from a planning perspective, early on, we were 100% reliant on overseas data. That's a good thing. That means that it didn't start here. The whole world was reliant on the early data coming out of China to plan and prepare. And so the early work that Professor Jodie McBurnan and I led, backed by a team of now over 30 infectious disease modelers and epidemiologists, that work was reliant on the experience from China and later on the experience from places like Italy. So we provided our first predictions. We provided our first scenario analyses showing possible future epidemic trajectories in Australia. We provided those to government in early February using estimates of the reproduction number from China and exploring a range of different severities, so case fatality rates and whatnot, based on some Chinese data and later updated to include data from Italy and other parts of Europe. And so data from overseas was absolutely crucial in the successful response we've had to date. It was what enabled us to alert the government that we were facing something incredibly serious, and it's what, in one sense, it's what caught the attention of the government and that helped them realise they had to respond. And so the early work we did was what drove us towards the policy response we've had so far. Once the epidemic reached Australia, the local data has obviously become more and more important. We started off showing the epidemic curve in Australia and estimates of the effective reproduction number. That's on the Australian data. Some of the detailed statistical work, it actually relies on global knowledge of the virus as well, in terms of how long people are infectious for and various other biological quantities. But we continue to monitor the global data. We still haven't had a large number of people with COVID-19 in our hospital system, and so we still draw on the far larger data set about hospitalizations from overseas to learn more about what the clinical pathway we might anticipate people will pass through in our hospital system in the future if the epidemic got worse. Because we should never refer to the epidemic in the past tense. It's still with us. It peaked a few weeks ago, but it could easily come back. I'll leave it there.
Sorry, Catherine, go ahead.
No, that's all right. Go for it.
I was going to move on, so no, if you have more to add, please do.
Oh, look, I was just going to say, I think there's sort of, there's been a bit of a focus on sort of Australian data, and there are lots of things that it is very, very important to measure within Australia because there are many things that are specific to different countries. But there are a lot of things about a lot of diseases that are very similar in different countries in terms of sort of the biological and the clinical impacts of the disease. They don't tend to vary very much between populations. We have some diseases that have sort of a significant element, like a genetic element, that play out differently in different places. but, you know, we're all learning from each other all the time in infectious disease control, because a lot of the really basic sort of natural history facts of infectious diseases are the same in people from all over the world. And we can also learn from control strategies. So, and we all do that all the time with other diseases in terms of what works in terms of convincing people to get vaccinated, what works in terms of screening strategies or how to set up hospital laboratories, you know, any number of things. You know, we learn a tremendous amount in Australia from other countries in terms of how to respond to different infectious diseases, and we're also be able to share our knowledge with other people in terms of controlling different diseases. So, yeah, there are some things that are specific to Australia that we need to figure out for ourselves, and we need to figure out exactly how this works in our health system or our regional communities or our remote Aboriginal communities. But there are a lot of things that are common or very similar around the world where we can all learn from each other completely legitimately, and the knowledge from other countries is incredibly, incredibly valuable to us, and our experience controlling the virus successfully will be incredibly valuable to other countries. So it's not necessarily the case that, you know, data from overseas are like a poor substitute for Australian data. They're often highly, highly applicable and very, very, very valuable.
We have one phone in, so we're just going to unmute them just to check if they have any questions.
Is that me?
I think you're on mute, Annika.
I think my host is no, someone has been unmuted. If they have any particular questions.
From News Corp here, can you hear me?
We can, Sue, go ahead.
Yes, so the question I wanted to ask is that the big problem with this virus is that we don't actually know whether people become immune to it, even if they catch it. And if that is the case, can we ever lift these restrictions, or are they going to be ongoing for years and years and years? How big a problem is that for you as you try to figure out how we get out of this?
So it's a very good question. And there is some uncertainty remains about how long people will be protected for once they get it. There are some really quite convincing studies in animals, so in primates, that show that following infection, we develop a strong immune response, and also these animals do, but they're well understood to have quite. What happens in the animals is a good predictor of what happens in humans. So that data is strongly suggestive, as is other sort of data about viruses like this, that most people, when infected, will or likely have a period of protection following it. Exactly how long, we don't know. It could be, you know, somewhere around a year. It could be quite a bit longer, maybe 2 to 3 to 4 years. This is potentially very similar to influenza, where the virus, partly because our antibodies wane through time and partly because the virus itself changes over the years, means that we get influenza multiple times during our life. So at the moment, it's true, we don't have enough knowledge yet to know exactly what each individual human's response to the virus will be after they've been infected. One thing I would caution is there has been lots of reports which are true that you can detect through a PCR assay fragments of the virus for a long time following infection. That does not necessarily imply that person is either sort of chronically infected or even that they've been reinfected. Because we know for quite a few viruses that the sort of residual fragments of the virus can hang around in the body for a long time. There needs to be further study on that as well. So where did this leave us? It's not, and this is sort of more of a personal opinion, but society can't live as it's living right now forever. It simply can't. Humans are not that sort of animal. You know, the scientists, humans are an animal, a species, and we are a social species. So how we transition to live with this virus as part of our ecosystem is incredibly challenging, but ultimately it's inevitable. We exist with many viruses and many pathogens. They're around flu, childhood bacterial infections, measles. There's all sorts of pathogens that are spread within our community, and some of them are very severe and some of them are rather more mild. And we have come to terms with living with them, and they kill people, and they cause morbidity and mortality. But early, as a new virus spreads in the population, it's far more confronting and far more difficult to manage and can cause lots of excess mortality. We know the story of measles arriving in South America, for example, hundreds of years ago. So those early waves of infection are confronting and incredibly, they cause a lot of harm. But that doesn't mean that it looks like that forever. And we ultimately, the diseases settle down to some sort of semi-steady state equilibrium, and we then learn how to both live with them psychologically and manage them in our health system. And the exact tempo of that will be different depending on how long. I've given a very long answer, I'm sorry. But the exact tempo of that will be different depending upon how long we're protected for it after we've been exposed. And we just don't know the details of that yet. But whatever they are, we'll be living with it for a long time.
So we've had a number of Australian patients who caught the virus. Has anybody looked at the antibodies that they developed and tested them? Is there any plans to do that? Should we be doing that?
Yeah, there absolutely should be. There are real challenges, like lab science challenges here, about having reliable assays and sharing that information around the world and learning how to interpret the measurements we make. These are more clinical and biomedical questions. So exactly what those pictures are is not entirely clear yet, but Australia has some of the world-leading virological and immunological researchers. We have very well-known labs around the country that drive a lot of research development in these sorts of areas across for this virus, for influenza, for other viruses. So Australia is playing its role there, and we will learn more about these sort of clinical and biological aspects over the coming weeks and months, and that will help us understand more how we will be living with this virus over the long period of time.
So there's another way to manage the pandemic, and that's to look at it from the point of view that the people most at risk are elderly people and those with comorbidities. Could we it's not a nice thing to say, but why don't we explored the approach of locking those people up and letting everybody else get about their daily business because they are less likely to die from the virus, and that would allow the economy to function in a more normal way?
I'm happy to take this one if you want, James. So firstly, it isn't possible because we can't completely separate older and vulnerable people from the rest of society. It's firstly an absolutely horrible thing to do, but it's also simply not possible. Older people interact with younger people constantly in their families, in caring relationships, both in terms of older people providing care to grandchildren and children, and younger people providing physical and other assistance to older people. So firstly, we cannot do that. It is not possible. Even if we could, though, allowing the epidemic to spread will have tremendous consequences for younger people. So firstly, as James said earlier, in Italy and now in the US, they are seeing huge numbers of young people hospitalised and in intensive care and dying with this virus. So it is not the case that younger people can catch the virus and be completely okay. Many younger people are getting severely ill and some are dying with the virus. On top of that, there are other health consequences with the health system being overwhelmed. So if we have overwhelmed emergency departments and intensive care units, that means many people will die. Young men will die after car accidents and motorcycle accidents. People of all ages will die with appendicitis when their appendixes burst. People will die from anaphylactic episodes with peanut allergies. Women will die in childbirth. Many people of all ages need emergency departments and intensive care. So the idea that letting the virus spread would only kill older people or people who are otherwise vulnerable, it's simply not true. It would have tremendous consequences for all of us. And yeah, it's just not the case that we can separate older people and younger people, even if we wanted to, which we don't because it's a horrible thing to do. There's not an older person in Australia who wants to spend the next 18 months in their house on their own. That's an awful, awful thing for anyone to contemplate. So it's not possible, and it wouldn't work anyway, even if it were possible.
Thanks, Phil. We'll just have to jump in. We've been going for over an hour now, so we probably need to wrap up. I'll just jump onto the last online question, which is from Ahmed at SBS. The New York Times reported recently about the missing deaths in COVID-19 data from a number of countries. Is that a risk here in Australia?
I think it's a risk everywhere, but it's far more, it's exacerbated when a country has an out-of-control epidemic that is putting their whole health system under severe stress. In Australia, our hospitals are actually really quiet at the moment because of all of the mitigation strategies and the cancellation of elective surgery and whatnot. And so we have an ability to be looking incredibly closely in our hospital system and broadly in the community for either illness or death associated with this virus. So at the moment, because we have the epidemic being under control, I believe that's a far less of an issue here. Once you have a system that is out of control or incredibly stressed, then you get what the New York Times has accurately reported.
And I guess one final question, which you may not be able to answer, but I feel it has to be asked. Are you able to put a time frame on allowing people with social distancing still in place to perhaps have small gatherings at their houses or very small group events? We're not talking large reopenings of pubs and clubs and things, but the ability to have dinner with a family member that doesn't live with you. Starting off small.
Yeah, well, I think these are exactly the sorts of things that we all crave. I know that in my family, my parents used to have, for the last decade, have had dinner once a week in my house or us at their house. These are things that we miss. And, I believe that carefully managed, they are quite likely to be relatively low risk events because they're repeatable and they're something that are manageable. The flip side of it is they are guaranteed to lead to some infections over the forthcoming weeks and months, and almost guaranteed to result in the odd tragedy. That's the nature of disease. This is already the case if we think about, if we step back enough, that's also the case with influenza in other years. If we have, children and adults are both susceptible to that virus. And if people have family dinners, for example, and, a healthy middle-aged adult infects an elderly relative at a family dinner and that elderly relative gets influenza and dies, it's a tragedy. But it's something that happens in society already. So the question, I think it's a really difficult policy question because society is paying so much attention, as it should, to coronavirus at the moment, that the occasional random events which will be reported on a lot more and identified, and they could easily be linked to a failure of a policy or the issue around. Now, I'm slightly hesitant to even brought this up because I think it's such a nuanced issue around what makes sense as a policy, and then the risk mitigation question, which is what a policy is about, but then what you may also expect to occur. I won't say any more, but except to say that I think those sorts of very small group, repeated week-to-week type interactions, if they're well managed and people don't, you cancel it this week because someone's got a sniffle, there's a good argument that those things should be able to occur, especially when the community prevalence is very low.
Catherine, anything to add?
Yeah, look, I mean, I completely agree. And obviously, James is absolutely right that everyone right now is feeling, the lack of seeing, their family and their close friends and the same types of social events that we're all used to participating in. And I think that's something that just absolutely everybody is struggling with. It's very, very hard for all of us. And I also agree that with James that, small gatherings are, on the lower risk end of the spectrum. Having dinner with a couple of friends is much, much lower risk than attending a large wedding, for instance. But that transmission at those types of events will occur. And I think it's important to be in mind as well that when it does occur, it's not necessarily because anybody did anything wrong.
Absolutely.
And I've been quite distressed to see some of the coverage where people are sort of singled out for spreading the virus, and we're seeing reporting of, this person did this and they went to this place and they gave it to this other person. And, that's a very sort of stigmatizing way of looking at this. This is an infectious disease that has evolved to exploit the way that we interact with each other. And we all need to be as careful as we can to avoid putting other people at risk, but inevitably some transmission will occur, and the more that we relax restrictions, the more transmission will occur. And I guess we all just have to sort of adjust our thinking a bit in terms of how we deal with that and how we think about that, because I think otherwise people will suffer inappropriate blame, and people will also feel tremendous guilt in some circumstances if they thought they just had a bit of a cough and then they went to a social event or they went to work and they did end up giving the virus to someone else. So I think we just need to be sensitive in how we think about that and how we talk about that and how we report on that, because a lot of people will feel, tremendous guilt and tremendous shame if it turns out that they have unknowingly given the virus to someone else.
Couldn't agree more, thanks.
We'll end it there as we've been going for quite some time. So that is it for today's event. If you do have any other further questions, feel free to send them through to the Science Media Centre and we can pass them on to James and Catherine, or contact us to see if they're available for interview. A full recording of today's presentations will be posted on Scimex shortly. Feel free to contact us direct, as I said, on 0871208666 or email us at info@smc.org.au. Thanks again to today's speakers, and thanks everybody for joining us for this online briefing. It's been wonderful.
Thank you.
Thanks.